Graft dysfunction, biopsy negative, what, why, and how. This is a difficult problem. There are a few well-known causes for this condition. Coming to the heart, this could be because of coronary artery disease, maybe from the donor heart, or a new onset vasculopathy. It could be from infectious myocarditis, commonly described as CMV and toxoplasma. It could be from recurrent myocardial disease, for which the original transplant was done, amyloid, sarcoid, giant cell myocarditis, hereditary hemochromatosis, and non-specific allograft dysfunction. This is likely to be the most common one you encounter, where you don't know why this particular patient is having graft dysfunction. This is defined as absence of vasculopathy in angiogram, but obstructive vasculopathy at arterial level. I think commonly this could be because of sampling error in patients with AMR and CMR. In our country, you could also add not having access to diagnostic facilities for an AMR. Your immunohistochemistry may not be perfect, so this is a gray area. And this category of patients responds to intensified immunosuppression. I'll give 4 or 5 examples that we have encountered. Of course, RV dysfunction could be because of residual coronary artery. I'll give 4 or 5 examples of graft dysfunction without biopsy being positive for discussion. The first patient is a young woman. She had a heart and lung transplant for Eisenman-Roth univentricular heart. She had uneventful surgery. She extubated next day actually. She was recovering very well. 2 weeks post-operatively, she had an episode of shock. In the morning, sudden hypotension, responded to fluids, required some NORAD, and had abdominal distension and had very high amylase levels. And she was CT scan and ultrasound basis diagnosed to have pancreatitis by the gastroenterologist and the surgeons. And she was managed conservatively, and she responded to it in a week's time, and she recovered completely. And on the 3rd week, when she was about to be discharged, she had a sudden severe hemodynamic compromise. So she was shifted to cath lab, and an angiogram was done along with the biopsy. The biopsy showed no evidence of AMR or CMR, and a few hours later the DSA was normal. The angiogram, unfortunately I don't have the angio right now, showed very diffuse tapering coronary arteries, almost like they were in severe spasm. We injected nitroglycerin to a few things. But the biopsy showed this, mucormycosis. Mucormycosis of the heart is described. Mucormycosis is described in post-solid transplants. This is the first one we encountered. I had never known mucormycosis to be inside coronary arteries. So it's something to keep account of, and it was there in the lungs as well. So you can have very severe graft dysfunction from other infections which you will not commonly think of. This actually responds dramatically to amphotericin, but in the post-operative setting where we have such a pathological aversion to any drug which increases creatinine, all our antifungal agents are much more mild, and caspofungin doesn't touch it. So this, I thought, is an important lesson for us to learn, because on the basis of this unfortunate experiment or episode, if some future life is saved, it's worth keeping in mind. The second example is this young boy, exactly 1 year ago, very severe biventricular cardiomyopathy. And as you can see from the echo on the left side, very sick. He had a 4 o'clock in the morning phone call from the ICU, and the nurse is talking to you, means the doctor is busy massaging. And this is exactly what happened. 45 minutes of massage. With an LV like that, we took him down, opened the chest, and put him on central ECMO. And after waiting for 3 weeks, we got a heart looking like that. Moderate dysfunction. This was refused by other units in our state, and quite rightly so. And we accepted it because he had no other chance of getting anything. He was too small to get a good VAD, and biventricular disease, in any case, long-term VAD is not possible. That donor had a cardiac arrest 10 minutes before the heart could be harvested. So we cross-plant and gave cardioplegia and accepted the organ. So technically it was a DCD donor. And post-operatively he had ventricular dysfunction, but it was manageable. On the night of surgery, he again had a cardiac arrest. We anticipated that. So in such patients, we keep the groin vessels taped and then close the skin. So we could institute a second ECMO on this child. And the ventricle recovered, and 2 weeks after the transplant, he is playing games on his computer in the room. 3 weeks later, this is the echo we see. Free TR, low velocity TR, RV dysfunction. So we shifted him back to the intensive care unit, started him with some inotrope, and before we could organize a biopsy, he crashed, so he had to be intubated, massage, recovered, and this is the angiogram. As you can see, very severe donor coronary artery disease. This is the reason I think the donor had a cardiac arrest. This is the reason the other units refused, which is fair enough. So what is good enough for a very sick patient is not appropriate for a more stable patient. As you can see, very tight LAD. I wish we had better methods of assessing donor coronary arteries in our setting. We don't. So this boy underwent stenting. And the child, the boy is 6 years old, the heart is older, and the LAD and RCA were stented. Unfortunately, at the end of the procedure, he sustained a third cardiac arrest. So it's not easy to massage in a cath lab. The damn tube is so close. But fortunately, since the groin wound had not healed, we reopened, and again 45 minutes massage, he was decerebrating. He woke up after 2 days. And by 3 weeks, the ventricular function had completely recovered. He had some TR, but now 1 year post-surgery he's fine. So ventricular dysfunction need not always be because of rejection. This is, I don't know whether this topic is restricted to the heart, and we can talk about lungs because the topic just says graft dysfunction. So I'll share a couple of lungs as well. This man, severe destroyed lungs. He was on ventilation for 3 months, episodes of sepsis, very sick, had a tracheostomy inserted before he came to us, underwent a bilateral lung transplant, did very well with 1 liter of oxygen, mobilized, was about to be shifted to the room with an X-ray like this before being shifted out of the ICU. He had profound hypoxia, very rapid onset over a period of 10 minutes, and had a cardiac arrest, was resuscitated. The surprising thing was his WBC count, which was normal in the morning, was 80,000. So you would think that's probably sepsis. Platelet count was again normal in the morning, it's 450,000. But what was interesting was the hemoglobin was 8 6 hours ago, and it's 14 now. Almost as though all the water has been sucked out of the blood, and his hemoconcentrated. His procal was normal. His CVP was very low. He was drinking volume. You could pump in 3 liters and and he had profuse watery secretions from the endotracheal tube on bronchoscopy. Didn't look like septic secretions. There was no, the gram stain was negative, and of course the culture was negative next day. And his X-ray looked like this, clearly florid. You can call it whatever you want, graft dysfunction, pulmonary edema. So we treated him with pulse steroids. The biopsy was negative, and he responded dramatically. ECMO was removed after 5 days, lost ventilator next day, and is shifted to the room with an X-ray looking like this. The histology came back as non-specific vasculitis, query autoimmune vasculitis. I don't even know what that diagnosis means, because it's immunofluorescence and IHC, whatever again I say, we sent it to 3 different labs. Each of them reported as negative for AMR, so we have to believe that. So I don't even know whether there is an entity called autoimmune vasculitis post-transplant. This is the first time I've heard of it. But he responded to steroids, so it's something. Again, this 70-year-old woman underwent a single lung transplant, was discharged home, readmitted with severe hypoxia, biopsy was normal, no sepsis, CT showed pulmonary thromboembolism, recovered completely with treatment. So again, graft dysfunction, which is not necessarily because of rejection. And finally, bilateral lung transplant in a 40-year-old woman, uneven full recovery, had 1 episode of rejection, treated with pulse steroids, recovered completely, and after 4 months presented with acute respiratory distress and no rejection on biopsy with very tight bronchial stenosis beyond the anastomosis, recovered completely with left bronchial stenting. So it's important to keep in mind that there could be other reasons why you can have graft dysfunction, and clearly the more you do, more aware you will be of other causes, because all of them are very well treatable if you actually can pinpoint the diagnosis. Thank you very much.